Hello and good evening, everyone. Welcome to our 19th BHVS virtual seminar. BHVS virtual seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by BHVS Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. We aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at BHVS Ethiopia, and it's a pleasure to have Dr. Hamelmal Gebeyehu here with us again, and to give us an update on the approach and management of CKD. For those of you who haven't attended the previous seminar, let me introduce Dr. Hamelmal to you. Dr. Hamelmal Gebeyehu is an assistant professor of medicine, nephrologist, and internist, and currently serving as a head of nephrology division under the Department of Internal Medicine at St. Paul Millennium College.
Okay, good evening again. So let's start this approach in management of chronic kidney disease. So before we start, CKD is a vast topic, and even treatment of each complication has its own guideline. But I will try to summarize as much as possible within the time we have, and we'll touch on practical points in management of CKD, and we'll discuss how to approach, how to diagnose chronic kidney disease. I'm sure most of you, there was a request for this session, so I hope it will be informative. So, like I told you, it's more a summary of the management of CKD. So any questions you have, please try to ask as much as we can, and I'll try to answer as much as I can within the 10 to 20 minutes I have. So to begin, my outline will be, there will be introduction, definition, staging. These are very important in the management of chronic kidney disease, etiology, and progression, diagnosis, and management of chronic kidney disease. So as an introduction, there is an increased burden of CKD over the past 20 years. So there is substantial worldwide variation in the burden of CKD, and worldwide diabetes is the most important cause of chronic kidney disease, and its contribution is important when it comes to causing CKD as well as mortality. So in our country, there are some studies of prevalence which put CKD around from 15 to some even predict up to 30%. Worldwide, the prevalence of CKD is believed to be 13%. So over the past 20 years, there's a trend in increasing burden of CKD. There is no evidence to suggest that CKD is increasing in our country because the studies have been done over a period of time, local studies and hospital-based studies showing different numbers of prevalence. There is no evidence that there is some increase in our country over the past decades, but we still need population-based study to assess the prevalence. But worldwide, it seems to be increasing. The role of CKD as a cause of mortality has also increased. Previously, there have been not enough evidence to suggest that CKD is directly related to mortality, but now we know throughout the last decade that CKD is a risk factor for cardiovascular outcomes, including cardiovascular mortality. So CKD directly as a cause of mortality has been more implicated in the evidence in the past decade. So most studies use only GFR and not albuminuria. So most prevalence studies or studies showing burden of disease do not use albuminuria criteria to diagnose CKD, rather only use GFR, and do not provide duration of greater than 3 months to confirm CKD. So the actual prevalence may be way higher than 13%. When you include those patients, just albuminuria and preserved GFR. This is true for patients with diabetes, for example, who have albuminuria way earlier than declining GFR, which we should still classify as having CKD because of diabetic kidney disease and start preventive measures. So albuminuria criteria is very important in the diagnosis of CKD, not only GFR, and confirmation for greater than 3 months is lacking in most prevalent studies. So for anybody trying to assess our situation, it's better to include these things. So premature death is far more common, a common result of CKD than kidney failure. So most patients die of cardiovascular disease before they reach dialysis. So before somebody develops end-stage renal disease, at earlier stages, cardiovascular mortality will take the life of the patients. When we are talking about CKD, we are talking about cardiovascular risk and cardiovascular mortality, because that's the most common cause of mortality in patients with CKD. As GFR decreases and albuminuria increases, this mortality increases in most causes of chronic kidney disease. So GFR also predicts, for example, patients with stage 4 to 5 CKD have significantly higher mortality than patients with stage 3 CKD. And the same is always true for albuminuria criteria. So we'll discuss that later. So rather than using single GFR and albuminuria, changes in measurement are more useful. For example, we will define what rapid decline means and how to define progression. So the target of CKD management most of the time is preventing cardiovascular death and delaying the progression of CKD. Delaying the progression is important in such patients. So mortality is highest in patients with dialysis, obviously. So patients with dialysis have very high mortality, especially those patients with diabetes have the highest mortality. Patients with polycystic kidney disease and glomerular disease have lower mortality. So patients receiving kidney transplant have much better survival in cardiovascular outcomes than patients with dialysis. So always it's better to, when we are planning renal replacement therapy, to direct patient towards kidney transplantation whenever possible, because cardiovascular outcomes on dialysis are unacceptable, and we have not reached an optimal survival and cardiovascular benefit with dialysis. Whichever mode of dialysis, hemodialysis or peritoneal dialysis chosen, always transplant is better for advanced or stage 5 CKD. So I generally avoid saying end-stage renal disease because it's ominous and does not really, reflect the hope that comes with renal replacement therapy. So it's not end-stage. Most patients who have at least, some form of income, have a future. So generally, I tend to avoid end-stage renal disease, refer to it as CKD5 or CKD stage 5. So let's come to definition. So this definition is taken from the KDIGO guideline. Unfortunately, in the 2012 guidelines, the last one we have, I'm sure there will be updates soon. They are planning to update the coming year. So in the coming years. So to define CKD, we need markers of kidney damage and decreased GFR. So either of those are required. Either of the markers of kidney damage or decreased GFR is required. What we mean by markers of kidney damage is proteinuria. So we'll classify albuminuria later on. Urine sediment abnormalities like RBCs in the urine, RBC casts, dysmorphic RBCs, any urine activity when it comes to especially RBCs and sometimes WBCs, depending on the pathology we are thinking. Electrolytes and other abnormalities due to tubular disorders, renal tubular acidosis is considered to be one of the causes of CKD, and also other abnormalities, genetic tubular defects are considered as markers of kidney damage. Histological abnormalities in biopsy, especially in glomerular disease, structural abnormalities, many urogenital abnormalities, stone disease, and history of kidney transplantation, or other causes of solitary kidneys are considered as CKD if they last for more than 3 months. Decreased GFR less than 60 is also, regardless of the cause, is also considered as CKD. So GFR categories 3A to 5. This is the general definition. So these abnormalities should persist for more than 3 months with implications for health. So the important phrase in this statement is the implications for health. For example, urine sediment abnormalities by themselves, for example, you may find a patient with hematuria without associated proteinuria, no decrease in GFR. It doesn't mean there is actually an implication for health in this patient. You just follow for a long period of time and may not amount to anything. And patients with very mild albuminuria, whom you are following without isolated albuminuria without any other abnormality, may also be questionable in such case. So there should be an implication for health. So there are drawbacks of this definition. As you can see, GFR less than 60, okay, we accept because anybody with impaired GFR is believed to have chronic kidney disease, and there are measures we should take as soon as we can. But markers of kidney damage without any decline in GFR may be, for example, let's say a patient has solitary kidney at birth. So this patient, by definition, has CKD. But most patients, survive with solitary kidneys for a long period of time. There is no medication to start in such patients, rather than some mild measures. So it's questionable that every abnormality qualifies as chronic kidney disease. So one of the drawbacks is it includes patients without parenchymal lesions. For example, like I told you, patients with stone disease, for example. Some patients may have stones on imaging. So by the definition, if the stone disease persists for more than 3 months, it's CKD. But it doesn't mean that patients have similar prognosis as with patients with parenchymal lesions. So we have to be careful in defining patients without any GFR abnormalities. And structural abnormalities without decreasing GFR. For example, some urogenital abnormalities, but there is no decline in GFR. Such patients may have intact kidney function lifelong, and they may not have any abnormalities at all throughout their life. So it's difficult to classify such patients as having CKD. The other thing, maybe, like I mentioned, stones, increased prevalence of decreased GFR and increased albumin to creatinine ratio in older individuals. So most current calculators for estimated GFR account for age. But if you don't use such formulas and if you use formulas that do not have age and do not correct for age, you may find that GFR declines after 60 years of age. GFR declines by 1 ml per minute per year. So that decline is normal because it's age-related, and more nephron loss is manifested in older individuals. So you have to account for these older subjects, and you can't classify them having as decreased GFR. So you have to correct for age as GFR decreases normally. So there are some, another drawback of this definition is there are some conditions where GFR may be less than 60 for better than 3 months, but there is no structural damage. For example, patients with heart failure may not have adequate cardiac output to maintain GFR. It doesn't mean there is structurally CKD, but by definition, patients are classified as CKD, kidney donor cell patients. There is no actual structural alteration, but GFR may be low, maybe less than 60. For example, in kidney donors, as a compensatory mechanism, GFR may be declined, but it doesn't mean that there is any structural abnormality, and we should do something about that. So another important thing in the definition of chronic kidney disease is the duration of greater than 3 months. So duration greater than 3 months is not put arbitrarily, rather it has prognostic implications. So there is enough evidence, like many evidence, if you look, to suggest that this 3 months is enough to differentiate from active in most scenarios. So the most important and the most reliable means to assess duration is obviously previous documentation of renal abnormality, but it's very difficult to find patients having, creatinine documentation before they are sick or before they come for evaluation. So even if you can ask yourself, how many of you have creatinine determinations in the past year? I'm sure it will be a small number. We are physicians, but still we don't creatinine, So even in the general population, it's very difficult to have a baseline creatinine or a baseline abnormality documented 3 months before, but that would be definitive. But you can estimate the duration of CKD based on clinical conditions. For example, somebody having shrunken kidney or very small kidneys, you know that this process has been going on for more than 3 months. So this is evidence-based. But having CKD is not equivalent to irreversibility. For example, patients with glomerular disease who may have glomerular pathology for many months or even a few years have the chance of reversal. Even if it's a chronic process, still there is a chance of reversal. So duration of greater than 3 months is not equivalent to irreversibility. So we see a lot of patients denied active treatment or treatment for their glomerular disease just because the disease has stayed long for more than 3 months. So for most causes, it's very difficult, but for some causes, it's important to know that the disease may be treatable, even if the duration is higher than 3 months. So GFR is the best overall index of kidney function. The problem with GFR is it does not assess the endocrine or metabolic functions of the kidney, right? For example, CKD NBD is not assessed by GFR. It just tells us the mere filtration function. But overall, it's believed to translate to overall decreased in kidney function. So normal GFR is about 125. So we say CKD when GFR is decreased by half, 60. When it's around 60 or less than 60, we say that there is chronic kidney disease. So the current estimating equations mostly use creatinine, but cystatin C can be used, not alone, but with serum creatinine. So decreased GFR can be confirmed, for example, in kidney donors and where you need, the exact amount of GFR you can measure, but that's a cumbersome process and we don't do it regularly. So you have to know that GFR is not, the optimal measure, but it's the best we have so far. Overall index of kidney function, even though it doesn't directly tell us whether there is also other abnormalities. So based on GFR, staging is based on GFR, albuminuria, and cause. So we won't discuss the cause in detail, but we'll discuss GFR and albuminuria categories. I'm sure you know kidney failure or CKD stage 5 is defined when GFR is less than 15, stage 4 when less than 30, and so on. So this number is very important, but we have to note that we have to see patterns of creatinine and stable creatinine before determining the level or before staging. So normal decline in GFR associated with age should be considered when staging CKD, and estimation formulas, usually the ones we have modern formulas which are easily accessible online and on applications have modifications or they account for this decline with age. Creatinines should be stable before estimating GFR, and staging you have to see 3 or 4 creatinines. The more creatinines you do, the more reliable GFR estimation becomes. The other is albuminuria category. So the KDIGO or other guidelines prefer albuminuria measurement rather than total protein measurement in the urine. So A1 category is less than 30 milligram per 24 hours, or less than 30 milligram per gram albumin to creatinine ratio. This is normal to mildly increased. It doesn't have very significant prognostic value, but it tells you to be alarmed and to follow the patient regularly. Moderately increased and severely increased hypoalbuminemia, albuminuria should be treated. So moderately increased is 30 to 300, and above 300 is severely increased. Severely increased proteinuria includes patients with nephrotic syndrome or other glomerular pathologies. Glomerular pathologies are included in the severely increased category. It includes these categories. And moderately, so another drawback is these patients may not necessarily have chronic kidney disease. And the other is moderately increased, 30 to 300 over 24 hours or milligram per gram. So this is another number which we should aggressively treat. So staging with albuminuria has great prognostic value in CKD patients, not only diabetic patients who have albuminuria early, but any CKD patient, albuminuria is associated with worse prognosis. The higher the albuminuria, the higher the mortality, regardless of the stage of CKD. And albuminurias are independently associated with increased cardiovascular risk. So in our setting, we do proteinuria. It gives us a rough estimate of total protein, so we can't stage based on that, but this is what the guidelines suggest. That's why I'm sticking to albuminuria measurement. So every CKD patient should have at least quantified amount of proteinuria if albuminuria is not possible. So this is the table we always use while presenting or while discussing. So this is the prognosis of CKD by GFR in albuminuria categories. We will see other prognostic factors later on, but if the stages, stage 1 and 2 and A1 category, there is low risk to the patient and you can just continue for follow-up. So moderately increased albuminuria in advanced stages of CKDs 3B and above is very high risk, and also we know that albuminuria declines when GFR declines in most patients because the kidney is scarred. So severe, regardless of albuminuria, stage 4 and 5 are at very high risk, and the risk increases as you can see as albuminuria and GFR. Albuminuria increases in GFR decreases, so this is very important in prognosticating patients and also very important when to screen for cardiovascular disease and when to refer. So we have seen definition and staging. Let's come to etiology of chronic kidney disease. So these four you see in this picture are the most common causes of kidney disease worldwide. So every patient does not, go out of this category. Either it's diabetes, hypertension, glomerulonephritis, or polycystic kidney disease. There are other causes not mentioned here, for example, stone disease, structural movement. This accounts for less than 1% in stone disease, interstitial nephritis in patients taking drugs or nephrotoxins, other nephrotoxic medications, and also the other causes which are not mentioned here are there, but the majority of patients are categorized into this group. So we have to know more and more recognized term, CKD of unknown cause. It constitutes for a portion of CKD patients, especially those who present late and you cannot work up for cause of CKD because of shrunken kidneys. You cannot do a histological examination, and the finding out the cause may not be important in such patients who come really, really late, because the management of CKD is the same regardless of the cause. Of course, diabetic patients, hypertensive patients may have their own specific therapy, and may have its own specific therapy, but in general, common pathways of chronic kidney disease are treated commonly, so it may not be essential to know the exact cause. So CKD of unknown cause is common, especially in setups where patients don't have easy access to early screening and treatment. Renal vascular disease put as a fifth cause, but now we know that most patients with renal vascular disease are hypertensive patients and have atherosclerosis of the renal arteries. Most patients with renal vascular disease as cause of CKD are exactly hypertensive patients who have atherosclerosis of the renal vessels. So most important causes are diabetes, hypertension, and polycystic kidneys, and the cause varies. For example, in Western societies, diabetes is the most common cause. In Asia, in Far East, it's glomerulonephritis. That's the most common cause. So there is significant regional variability in cause of CKD. So other than the causes, more important would be risk factors for CKD, some of which are causes, but not always. So we have to know these risk factors for CKD so that we can screen these patients regularly. That's more important than looking for the cause once the patient has developed CKD 4 or 5. So risk factors are monogenic kidney diseases like polycystic kidney disease. If somebody has polycystic kidneys in the family, it's better to screen the siblings, at least if they are above age 30. podocytopathies, including steroid resistance, nephrotic syndrome, complement abnormalities like HOS. This should be like, these are patients you should follow for development of CKD. We have seen very young patients who have been on nephrotic syndrome management during their childhood developing chronic kidney disease. So this is a very important risk factor. Genetic disease like Alport syndrome, congenital abnormalities, especially reflex disease, should be looked for in patients with who develop CKD at an early age. Type 1 or type 2 diabetes, not all patients with diabetes develop CKD. Of the patients with diabetes, 30 to 40% develop chronic kidney disease. So that's a large number. So diabetic patients should be screened and followed because, like I said, 30 to 40% will develop CKD during their lifetime. Poorly controlled hypertension, of course, is a problem in our setting. Most patients do not take hypertension, but hypertension takes a long time to cause CKD, like decades. For example, a patient should have uncontrolled hypertension for 10 years, 20 years to develop hypertensive sclerosis. So most patients who are labeled as hypertensive, having hypertensive nephrosclerosis, usually have glomerular disease diagnosed at a very young age, manifesting with hypertension. Obesity is an important risk factor for CKD. We don't see a lot of obesity here, but it's common and we have to address it to prevent progression. Nephrotoxins. So in clinical practice, we see a lot of patients with chronic inflammatory disorders like gout, arthritis, taking nephrotoxic medications, and they are taking non-steroidal anti-inflammatory drugs for a long time, developing chronic kidney disease. That's one important risk factor we should address. Malignancy, episodes of acute kidney injury. For some of you who attended the last lecture, I have been discussing regarding acute kidney injury as an important risk factor for chronic kidney disease, especially dialysis requiring acute kidney injury should be followed lifelong, and all other measures should be taken so that it does not lead to chronic kidney disease, because there is nephron loss in patients who have developed significant acute kidney injury. Low birth weight individuals, obstructive uropathy, these are some of the causes of, or some of the risk factors for chronic kidney disease. So when we come to the diagnosis of CKD, so let's see the approach. I will summarize most of it because it's very extensive to work up patients with CKD, and there is no as such variation with stage. So for all patients, there are some things we should do. So I will focus on those rather than on specific pathologies. Like I said, glomerular disease, I was talking about last time, is a unique disease entity, and it's, I think, ignored in our setting, but we see it being the cause of most of our CKDs. Most patients are not treated when the glomerular disease was treatable. So I will not go into that, but I will discuss everything you should do to diagnose and treat CKD patients optimally. So patients from stage 1 to 2 CKD are usually asymptomatic, and like stage 3 onward is the strict definition of CKD. This 1 and 2 CKD are at-risk individuals. I have mentioned all the risks. So patients with the above risks should be screened for CKD. GFR should be estimated, creatinine should be regularly estimated, and albuminuria. So I see patients in diabetic clinics, for example, in our country, we see a lot of diabetic patients just coming with creatinine visit after visit, and that's very wrong. At least to the minimum, we should have dipstick proteinuria or 24-hour urine protein should be done. So quantification of protein is very important in such high-risk patients, stage 1 and stage 2. And knowing the risk factors is also very important. So from stage 3 onwards, definitely, creatinine will be impaired, GFR will be impaired, and patients start manifesting with various symptoms, especially anemia. Anemia comes very, very early in CKD, especially in diabetic kidney disease. Anemia can come as early as stage 2. Stage 3 onwards, most diabetic patients have anemia. Diabetic kidney disease patients, I mean. So above stage 4, almost 80 to 100% will have anemia, regardless of the cause. Mechanisms of anemia are clear. protein deficiency, iron deficiency, other substrate deficiency, chronic inflammation, all these things contribute to anemia. So early symptoms are often attributable to anemia. In patients stage 3 onwards, they will have fatigue, they will have poor appetite, and general feeling of loss of well-beingness. So 1 and 2 usually don't expect any symptoms, but screen. That's my message to everyone who's attending, especially diabetic patients, other patients with risk should have proteinuria measurement at least and should be on anti-proteinuria therapy and other therapies as well. So from anemia is an important symptoms of anemia come very early. Other symptoms of uremia and the like will come also. So we will not discuss clinical features because I'm sure everybody's aware of those. So step 1 is doing renal function test and urine albumin and protein. We know that diagnosis of CKD relies on creatinine mostly. Some equations use creatinine cystatin C and urine albumin or protein. As we previously discussed, definition and staging depends on this measurement. So creatinine should be measured under steady conditions. For example, patients on AKI with AKI should not have creatinine measurement to estimate GFR, and patients should have a few creatinine measurements, for example, 1 or 2 creatinine measurements and stable creatinine to estimate GFR. So, and you have to also do more creatinines if possible. The preferred equation is CKD EPI, but you can use other equations, but you have to understand the drawbacks. I will not go into this in this lecture, but there are drawbacks with MDRD equations and other equations. CKD EPI is the preferred one, but make sure the creatinine is stable before calculating GFR. Quantitative measures for albumin, of course, we are always talking about this, but in clinical practice, our rate of determination 24-hour protein patients with CKD is very low, but at least we have to, determine. The KDIGO recommends albumin as the best marker, and make sure albuminuria is persistent. It lasts for more than 3 months because many conditions result in, false proteinuria, like exercise, any form of physical exercise, infection, acute stress, orthostatic proteinuria has also reported. So make sure proteinuria is persistent before staging. So the first step 1 is do renal function test and urine albumin or protein, quantify the protein and make sure it's persistent. Step 2 is confirming chronicity. So previous determination of serum creatinine is the best, but we don't know in most patients. Previous diagnosis of CKD patients are often told that they have kidney impairment because of their diabetes or hypertension. So confirming chronicity is very important. And abdominal ultrasound is an invaluable tool in assessing chronicity. So small size kidneys, so by small size, we mean less than 10, but for patients with short stature, 10 patients, we may use 9 as cutoff. But we use 9 to 10 as low size. 8 is definitely shrunken. 9 is, we usually use borderline. We don't have local data, but at least you can see the patient and see whether that patient is short or body habitus is important in determining the size. The importance of this is we may label patients with normal or kidney function or normal size kidneys as CKD. So when we use higher numbers, for example, if we use 10 in our population, it may overestimate the patient as CKD, and we may, push the patient towards unnecessary diagnosis. So be careful when determining the size. Cortical thinning, structural abnormalities, these are important factors to assess. So we have to confirm chronicity because acute kidney injury, usually there is reversal. It doesn't mean, like I said, all CKD is irreversible, but chronicity should be confirmed to label as CKD because the management will be different. Once we label as CKD, we focus on delaying the progression and other factors rather than actively treating the cause. When we label the patient as AKI, we treat aggressively the causative agents. But once we define CKD and confirm chronicity, we focus more on other factors we will discuss. So the third step after we do renal function based analysis is look for causes or risk factors. Looking for the cause may not always be important or beneficial. It may not always be cost effective, but there are some causes that are relevant. For example, diabetic kidney disease as a cause of CKD, the management is different. We have to control the diabetes aggressively, and we have to diagnose and treat diabetes, look for other complications. So hemoglobin A1C should be done in all patients with CKD. Looking for congenital abnormalities, younger patients, for example, reflux, toss. So relieving this if there is obstruction, and treating structural abnormalities may prevent further cause of further kidney damage. The other is chronic infections, hepatitis, HIV. This as cause of CKD they have been clearly implicated as causes of CKD. So we have to look for these chronic infections, which are easily treatable, and treating them may have some effect on CKD progression. Malignancy should always be looked for in any patient coming with chronic kidney disease. Not always, but depending on indications, and if you don't know the cause, and depends on clinical conditions. So looking for the cause is not always of cost effective. Sometimes we look for causes historically, and we try to further work up when we are evaluating patients for kidney transplantation, because some causes may be recurrent post-kidney transplantation. So when we look for cause or risk factors, kidney biopsy can be considered. So it's not an absolute contraindication in patients with CKD. In patients with obviously shrunken kidneys, small scarred kidneys, 8 centimeter, 8.5 centimeter, very difficult to do kidney biopsies because low yield in such patients, but there is also high risk of bleeding because the kidney is scarred. Rather than a normal parenchyma, you are risking the patient for bleeding if there is fibrous tissue, obviously. So benefit and risk should be weighed, but borderline kidneys, like kidneys with normal size, and we don't know the cause, and we suspect that it may be reversible, there is still room to do kidney biopsy in CKD, especially in glomerular disease such as lupus nephritis and other glomerular disease. We can do biopsy. It's not an absolute contraindication if you are not sure about the cause and if you think there is some reversibility. Because rather than going for supportive management and delaying progression, if you believe that the patient benefits from active intervention, it's better to always go for biopsy, look for the cause, but we should outweigh risk and benefits. So the other important step is searching for complications. So serum electrolytes, hyperkalemia, and hyperphosphatemia should be looked for at least in patients with CKD, sodium disorders. All electrolytes should be done. Acid-base abnormalities, anion gap metabolic acidosis should be looked for, treated, and CBC should be done for every patient, because I told you, like, anemia comes very early. Even if patient is not anemic, iron deficiency should be assessed in patients whenever possible. Even patients with mild anemia, you should do iron studies and assess for iron deficiency and replace the iron. The other is mineral bone disease workup. So we don't see a lot of actual bone abnormalities in patients with CKD because most patients are treated early before renal osteodystrophy occurs. But unfortunately, we see a lot of renal osteodystrophy in pediatric patients who have started dialysis early and have been on treatment. Despite treatment, these patients develop bone abnormalities. So by CKD MPD, we mean it's not actually a bone disorder, rather it's a biochemical disorder of phosphorus, calcium, and PTH abnormalities. Treating biochemical CKD MPD will result in lower cardiovascular mortality and lower, bone abnormalities. Cardiac evaluation is very important. So that would be the next step. So first, to summarize, renal function test and urine albumin, we confirm chronicity, look for causes or risk factors. This may not always be essential or cost effective, and search for complications and look for cardiovascular risk factors. So CKD is one of the well-recognized risk factors for cardiovascular mortality. So at least in patients, we should screen for hypertension. Most patients with CKD will have hypertension. Usually it's not feasible to know, or it's not possible to know whether hypertension or CKD came first. higher levels of LDL should be looked for. Lipid panel should be done for all patients with CKD at least, and if there is high cardiovascular risk, patients should be on statin. Diabetes screening, like I said, should be done regularly, and historically, smoking, physical activity, and other risks of traditional risk factors should be looked for. Non-traditional risk factors, albuminuria always should be quantified. Anemia has been associated with increased cardiovascular mortality in patients with advanced CKD, especially CKDs 4 and 5. Fluid overload, electrolyte imbalance, all these things should be looked for in patients. So at least on investigation, we should have a lipid profile for every patient, screen for diabetes, have albuminuria, and whenever possible have homocysteine levels. And anemia should be worked up early. Once patient reaches stage 3, workup for anemia should begin. So this is the workup of patients in general with chronic kidney disease. So when we see the management, there are different management options for patients with CKD. So the first is slowing progression of CKD, treatment complications, and planning renal treatment of complications, planning renal replacement therapy, and when to refer to a nephrologist. So slowing to the progression of CKD is the most important aspect of management in patients with CKD, because once patients reaches CKD stage 5, you either choose dialysis or kidney transplantation, and there is no confusion regarding that. There are different guidelines for kidney transplantation and different guidelines for hemodialysis or peritoneal dialysis, and patients have their own management. What we are focusing on in this presentation is slowing the progression of CKD. So rapid progression is defined as sustained decline in estimated GFR of more than 5 ml per minute per year. So in such patients have very rapid progression, and we should, look for other causes or look for precipitating causes in such patients. So we have to slow progression of CKD. We have to limit as much as possible the GFR decline in patients with CKD. So risk factors for CKD progression are obesity. Obesity is a very important risk factor. Smoking, uncontrolled diabetes, uncontrolled hypertension, albuminuria, dyslipidemia. So all these things should be addressed to slow the progression of CKD. These are the risk factors, but there are also other risk factors like age, AKI, and other things we'll discuss. So to prevent the progression, what we have to do is control the BP. One of the steps in dealing the progression is controlling the blood pressure. So individualized BP targets may be there. In general, BP should never be more than 140/90. So the KDIGO prefers 130 by less than 130 by 80. But the 2021 KDIGO guidelines suggest hypertension, blood pressure in non-dialysis CKD patients to be kept less than 120 by 80. This may be a little bit low for patients who are at risk of developing complications from antihypertensive medications, elderly patients, patients with autonomic dysfunction, patients at high risk for developing hypertension. So individualized targets may be used, but the current consensus or the current guideline is to keep blood pressure as low as possible. So you have to measure for orthostatic hypotension in the patient's symptoms of drowsiness and things like that when you start BP. So there is the cutoff 120 by 80 in the recent guideline, but individualized targets can also be used. And RAS inhibitors are strongly recommended in patients who have diabetes and proteinuria, but also for other patients, you should go for ACE inhibitors or ARBs as first line. So BP control is very important. So the cutoff is less than 120 by 80, but that may not be feasible in most patients. So at least we should keep it less than 130 by 80. So treatment of albuminuria. So RAS inhibitors like CKD of any cause with albumin, with severely increased albuminuria, that is greater than 300, should be started on RAS inhibitors, whether they are diabetic or non-diabetic. For hypertension control, you can choose any of the antihypertensives, but we strongly recommended our RAS inhibitors, especially in diabetic patients and patients with proteinuria. But for other patients, there is no preference of drug So ACE inhibitors and ARB used in CKD. So for both diabetic and non-diabetic adults with CKD and urine albumin less than 30 and BP greater than 140/90, BP lowering drugs should be used. So anybody non-diabetic or diabetic above systolic 140 and diastolic 90 should be on medication. And the other is diabetic and non-diabetic adults with urine albumin creatinine, which is moderately elevated, and BP is less than 130/80 should be treated. So 130/80 is proteinuric with ACE inhibitors or ARBs. So ARBs or ACE inhibitors should be used in diabetic adults with CKD and moderately increased proteinuria. And they should be used in both diabetic and non-diabetic adults with CKD, which is significant increased proteinuria. So more evidence are in patients who are diabetic with whatever degree of proteinuria, and both diabetic and non-diabetic with significantly increased proteinuria. So in non-diabetic, non-proteinuric patients, you can use any of the medications. So the other thing I did not mention here, because it's not yet included in the CKD guideline, has not been updated in the past 9 years, is the SGLT2 inhibitors. I'm sure there are different evidence you have seen regarding SGLT2 inhibitors. They're not in the guideline yet, but they will be, because they have shown significant benefit in patients with CKD, diabetic or non-diabetic, in slowing progression of chronic kidney disease. And I think there are even, there is overwhelming evidence that SGLT2 inhibitors have very high protection against rapid decline in GFR, and initiation of dialysis has been postponed or delayed by decades in patients, estimated to have been delayed by decades in patients who use SGLT2 inhibitors. I'm sure it will be included in the upcoming guidelines. So in addition to ARBs and ACE inhibitors, please use SGLT2 inhibitors in CKD patients of any cause, more in diabetic patients, but any CKD patient can benefit from SGLT2 inhibitors. So it's not in the guideline, that's why I did not put it here. So optimal diabetes control is the third thing you can do to, decrease the progression of CKD. 7% is put in many guidelines, diabetic guidelines, the new 2020 diabetes in CKD guideline, KDIGO, all recommend 7%, but this may be too low for some patients, especially patients with advanced CKD stages 4 and 5. You may go for higher targets, like 8%, less than 8% may be used. Patients with hypoglycemia risk, those with CKD, advanced CKD, 7 may not be the optimal target, but it's better to put it close to 7 in patients. But you can have individual targets. There are different targets for different patient groups, and see your patient's condition. If are they at high risk of hypoglycemia? Do they have other abnormalities, hypoglycemia, unawareness, old age? These patients should have higher targets, but generally, to delay progression of CKD in most patients, A1C of close to 7 is recommended. The other is preventing further injury. So preventing acute kidney injury in CKD patients. So on top of acute kidney injury, on top of CKD, if there is acute kidney injury, progression of CKD or GFR decline will be faster. So patients at risk for CKD are older patients, and at least for AKI are older patients with declining GFR. So the higher the stage of CKD, the higher the risk of AKI. So it's better to prevent AKI whenever possible. When patients are admitted in low fluid state, in acute illness, better to supplement fluid follow for acute kidney injury. The other thing is preventing and treating infection timely. The same population, elderly CKD patients, are at increased risk of infection. So timely treatment of infection will result in reduced rates of septic ATN, which will result in further CKD progression. Avoiding nephrotoxic medications, especially should be cautious when using diuretics in CKD patients. Should be cautious when using non-steroidal anti-inflammatories. Better avoid non-steroidals Overall, antibiotics should be used cautiously. Virtually any drug has the potential to cause nephrotoxicity. So adjusting drugs for CKD, that's great. So depending on the level of GFR, we should adjust drugs if they are nephrotoxic and have to be used. Some drugs better to avoid overall, like non-steroidals and aminoglycosides, should be avoided. Contrast, should be careful in patients with CKD. CKD is the most important risk factor for contrast. Other measures, smoking cessation, definitely. Most of us don't ask about smoking, and like we're not stressing on the direct relationship of smoking with CKD. There is ample evidence suggesting that smoking is directly related to progression of CKD and also cardiovascular mortality in patients with CKD. Exercise, weight loss, dietary modification, low sodium diet, less than 1 gram, less than 1 to 2 gram, and protein restriction in non-dialysis CKD. In dialysis CKD, protein restriction may have its deleterious effect, but in non-dialysis CKD, generally restricting protein to less than 0.8 gram per kg per day may have benefits, but we have to be careful about malnutrition as well. Treatment of hyperuricemia clearly has been shown to delay progression of CKD. Treatment of vitamin D deficiency also another thing which I did not mention here. Lipid lowering therapy, very important in patients with CKD, but we have to be cautious in patients with advanced CKD. Especially stage 5 CKD, we generally do not start initiate lipids, but recent evidence suggests that lipid lowering therapy, if the patient has high atherosclerotic cardiovascular risk, we should initiate statin therapy regardless of the stage. But in stage 5, we generally do not, start lipid because safety issues are there. Treatment of complications, so I will not go through every complication, but not all complications appear in all individuals at the same stage. Some patients may not have anemia even with advanced CKD. That's not a very large number of patients. So everybody will, it's not linear. All patients will not have all complications at each particular stage. So screening is mandatory. Once GFR is less than 45, we have to start screening for complications for mineral bone disease, for anemia. So once GFR is dropping below 45. Not all derangements are symptomatic. For example, anemia is well tolerated in CKD. Hyperkalemia is well tolerated in CKD. May not result in any symptoms and may not be treatment in most patients. So fluid abnormalities, just to say a few words, more complicated and more severe as GFR declines. Hypovolemia results from vomiting, excessive use of diuretics, polyuria in patients with urine concentrating defects like obstructive uropathy and other pathologies, infection. This all results in hypovolemia, and there is a tendency by physicians not to give adequate fluid in patients with CKD for fear of fluid overload, but you have to see the clinical condition and do adequate volume assessment and replace the fluid, and do not fear fluids in patients with CKD. For fear of congestion, we see a lot of patients dehydrated and having worsening renal function despite having such conditions. Hypervolemia is more common, so defective salt and fluid handling in CKD results in hypertension and edema. Most patients have hypertension not because of vascular abnormalities, but rather from fluid retention. So treatment, obviously, if they are hypovolemic, try to make them euvolemic. Hypervolemia, better treated with loop diuretics. Thiazide diuretics may also be effective in earlier stages of CKD. In stage 5 CKD or CKD, GFR is less than 15, thiazide diuretics stop working, so there's no use in giving, but recent studies suggest that they may have some benefit after all, but more studies are needed before suggesting thiazide diuretics in patients with GFR less than 15. Hyperkalemia is the third electrolyte abnormality in CKD patients, but CKD patients tolerate hyperkalemia. So you have to be ECG before deciding on treatment. Most patients tolerate hyperkalemia of 5 to 6 better when they have chronic kidney disease. Above 6, you should worry, but 5 to 6 may be okay in CKD patients. And because they have been hyperkalemic for a while, in cardiac status tolerates hyperkalemia more. Sodium disorders should be managed. We'll not go into details. So I would like to say a few words about treatment of CKD, MBD, and anemia of the complications of CKD. So before treating mineral bone disease in CKD, a battery of tests should be sent. So you should not decide on one abnormality alone. So serum calcium, preferably ionized, should be done, phosphate, PTH, and intact PTH is preferred, and vitamin D. So all these things you should take into consideration. For example, there is no rush to treat asymptomatic hypocalcemia. We see a lot of patients on calcium because their calcium is low. Our target is not increasing calcium or normalizing calcium, rather optimizing PTH and phosphate levels. So we should see everything together before deciding. Treating biochemical abnormalities prevents osteodystrophy. We don't see a lot of bone disorders, but also it takes from cardiovascular mortality and calcium accumulation in the cardiovascular structures. Extra bone calcifications should also be avoided. Vitamin D level should be determined in all patients with CKD. We don't really supplement vitamin D, but low vitamin D should be replaced. So this is a general recommendation. So you have to see, you don't have to memorize everything, but you have to analyze. For example, if calcium is low, phosphate is low, and PTH is high, you should use calcium-based phosphate, binders. If calcium is low, phosphate is low, and PTH is high, non-calcium phosphate binders. Sorry, the phosphate is high in such cases. And if there is high phosphate, normal PTH, and normal calcium, you should use non-calcium phosphate binders alone. And the other thing is when calcium is high, despite very high PTH level, calcium mimetics should be used, and also parathyroid surgery should be considered. So the message is you don't need to memorize everything, but to decide after seeing all results of calcium, phosphate, and PTH before deciding on therapy. So treatment of anemia, general principles, it's also an extensive topic. There is a separate guideline for anemia in CKD. But the general principles is to avoid blood transfusions in patients with anemia of CKD. There is risk of fluid overload, sensitization for future transplant, and hyperkalemia. So chronic anemia is tolerated very well in patients with CKD. So no need to transfuse patients, even if hemoglobin is 6 or 7, unless the patient has severe symptoms of anemia or the patient is in heart failure. You don't need to transfuse every patient, and we do not use hemoglobin cutoff in patients with CKD at all. Rather, we decide based on clinical conditions. So if the patient is debilitated, has serious symptoms of anemia, or is in impending heart failure, we should definitely transfuse if it's life-saving to the patient. Otherwise, the mechanism is not blood loss, it's equating deficiency and iron deficiency, so we should focus on that rather than transfusion. So another principle is considering anemia treatment when hemoglobin is around 10 grams per deciliter. Less than 12, we should consider treatment and plan treatment, but when hemoglobin is around 10, we should definitely start. Treatment, it's individualized target. There is no direct number, but in patients higher than 10, we may consider treatment of anemia if we want to avoid blood transfusions and we want to transplant. And we have to always replace substrates before initiating erythropoietin-stimulating agents. Iron should be replaced, and other substrate deficiencies, B12 and folate. Folate deficiency is very common in patients on dialysis, so folate and B12 should be replaced. IV iron is the preferred option. PO iron is not effective at all in CKD patients, so there is no need to try for PO iron. Put patients on PO for a long period of time. Just go for IV iron if hemoglobin is less than 10 or even greater than 10 and there is iron deficiency anemia. Hypoxia inducing factor inhibitors, vadadustat has been, and other drugs, similar drugs have been approved, not in the guideline yet, but they will be in the next guideline for sure. But these are very expensive and will not be discussed here, but they are the new therapies for iron. So erythropoietin stimulating therapy. In patients, non-dialysis patients, hemoglobin greater than 10, we do not start erythropoietin treatment if non-dialysis and greater than 10. Non-dialysis patients with hemoglobin less than 10, whether to start erythropoietin therapy should be individualized. If the hemoglobin is falling and there is a response to iron therapy and you want to decrease transfusion, you may start. CKD dialysis patients, erythropoietin therapy should definitely be started when hemoglobin is 9 to 10. So we don't want hemoglobin to be above 11 or 12 because there is risk of stroke, headache, and other complications are associated with erythropoiesis. So the target in dialysis patients is 9.5 to 11.5. So when it's 9 to 10, you should definitely start therapy. So trying to coming to the last section of my presentation is planning renal replacement therapy. So that's an important factor in CKD management. Transplantation is always preferred over dialysis. Preemptive transplantation, that is transplantation before initiation of dialysis, should be considered whenever possible in patients with GFR less than 20, but don't have symptoms of dialysis, uremic symptoms that warrant dialysis. So diabetic patients have the worst outcome on hemodialysis. So options of renal replacement therapy in vascular access should be discussed with the patient once GFR falls below 30. So indications for dialysis in patients with CKD are similar to those with AK. Additional indications may be refractory hypertension with more than 4 drugs if the blood pressure is not controlled, peripheral neuropathy, extensive pruritus. These are additional indications. Otherwise, indications are the same as acute kidney injury. But before indications come, if the GFR falls below 30 ml, we should counsel the patient and at least plan future renal replacement therapies. Less than 30 months, stage 4 CKD should be counseled. At least we should plan vascular access, place vascular access in patients you predict progression, hypertensive diabetic patients, proteinuric patients, or in general, you see the pattern of GFR and you expect this patient to have worsening in the coming year, you should place a vascular access as soon as possible. And then this gives you time, if the vascular access fails, to have another vascular access implant. And vein preservation for vascular access, most of us neglect vein preservation. Blood is drawn the cubital area, which will scar the veins and phlebites to develop, and we'll have small veins at the end of the day for fistula. And choosing mode of renal replacement therapy is transplant, feasibility, hemodialysis, peritoneal dialysis, home dialysis may be chosen. Even there are people in our country who are doing home dialysis. So planning should start once patient reaches stage 4 CKD, and vein preservation, vascular access placement should be done at this time. So the other thing is when to refer to a nephrologist, AKI of any severity in CKD patients, because fluid management and AKI management should be optimized to prevent further progression. Rapid fall in GFR, like I mentioned, more than 5 ml per minute per year. If GFR is less than 30, definitely should be referred to a nephrologist. Progression of CKD, which we defined earlier, and active urinary sediment, hematuria, RBC casts, these things may need further investigation. And refractory hypertension, more than 4 drugs, these patients should be referred to a nephrologist. This is the KDIGO recommendation, more or less what I said. If any patient with severely increased albuminuria or proteinuria and above stage 3A CKD should be referred to a nephrologist. This is the albuminuria criteria. Other indications, hemoglobin less than 12, significant CKD, MBD, suspected hereditary cause of CKD should be better managed, and screening should be done for with nephrologists. Stone disease with indications for metabolic workup should also be referred. I know I took a lot of time, but thank you. I'm sure you found a nice summary of CKD management in this presentation. Thank you for your attention. If you have any questions, I see a lot of questions in the Q&A section. We'll answer soon. Thank you. The first question looks interesting. How do you approach patients with high PTH value and low vitamin D level? So you supplement vitamin D, means 125 hydroxy vitamin D, not active forms. So you supplement with vitamin D. But if the PTH is greater than 700 or 800, you don't need to do vitamin D, just supplement active forms of vitamin D. Low PTH and high vitamin D in CKD patients, low PTH, just leave it, don't treat. Okay, so leave it there. What cutoff value should we use for PTH? I didn't mention this because it's not strictly put in the guideline, but 3 to 9 times the upper normal limit in dialysis patients, and generally more than 600 is indication for treatment. So to start vitamin D, active form of vitamin D, generally 700 to 800. To start treatment, go for 600, but there is no clear indication. So I've talked about enalapril, it's indicated for albuminuria all the time, so I'll not go through this. Can we just use abdominal ultrasound findings without creatinine? Very difficult. You have to confirm that there is decline in GFR, but by definition, ultrasound abnormalities are classified as GFR, but with implications for health. So you cannot use ultrasound without creatinine. Everything has to go together. Lipid lowering in CKD progression is definitely, there are new evidences suggesting you should start statin therapy. They may not have direct relationship with CKD progression, but they protect patients from cardiovascular mortality and may have some effect with CKD progression. So an interesting question here, calcium channel blockers in treatment of proteinuria and hypertension, yes, but not as first line. If patient has contraindication for ACE inhibitor, and if ACE inhibitor or ARBs and any other proteinuria measure cannot be used, you can use verapamil in such patients, and we have been using verapamil. But the problem is that proteinuria decline is modest. It's not as effective as RAS inhibition, but you can use an dihydropyridine calcium channel blocker. Especially, we have a lot of experience with verapamil. SGLT2, which one is best in CKD? I'm not sure. Dapagliflozin has been shown in DAPA CKD. Empagliflozin also both have very benefits in CKD. I'm not sure which one drug is better. Use of ACE inhibitors in high creatinine patients? Yes, that's the whole point. In patients with established CKD, you should use ACE inhibitors. You shouldn't, like in advanced CKD, if you mean in CKD stage 5, you still have to use ACE inhibitors. It will prevent further progression and further outcome, but you have to be careful about hyperkalemia. So any stage patients should start, but caution with initiating in patients with stage 5 CKD. Stage 4 and above, you should use. High creatinine is an indication to use inhibitors. Monitoring should be done. When you start ACE inhibitors, you should check for creatinine and hyperkalemia 2 weeks after initiation, and then continue. If it's tolerated by the patient, should go for maximum tolerated dose. Advanced CKD, there is a controversy below GFR of 15, but still you can use with if you are able to monitor the patient. Role of RAS inhibitors in non-hypertension but proteinuric patients, yes, I've already mentioned. It should be used in severely increased albuminuria, greater than 300 per 24 hours. Hold when there is persistent hyperkalemia. Hold during ill period if you want to prescribe. Don't prescribe non-steroidal anti-inflammatory drugs, but you can temporarily hold RAS blockers in patients at risk of AKI or infections and who are at increased risk of acute injury or established acute injury. We can hold RAS blockade, but don't prescribe non-steroidals in patients with CKD. Yeah, on AKI or CKD, better to hold RAS inhibitions temporarily. Which formula is preferable? I've already mentioned CKD EPI is the most preferable and validated. In anemia with normal iron studies, do we still supplement with iron before initiating equating therapies? Where there is in dialysis patients, we should supplement maintenance iron, but in non-dialysis patients, not really. BUN cutoff for renal replacement therapy, we don't have BUN cutoff, but we have GFR cutoff sometimes. So in GFR less than 10, it's better to consider dialysis, even if there are no indications. It's not a strong consideration, but if GFR falls before 10 or below 10, and some say below 8, we may need to start renal replacement therapy, even if there are no symptoms, because these patients are at very high risk for complications. So you are right, there is a cutoff for number of laboratory cutoff, but not BUN, rather GFR cutoff less than 10 or less than 18 centimeters. Pure iron just doesn't work because of activation of hepcidin pathway. So IV is preferred all the time. It's related to hepcidin and chronic inflammation. That's why pure iron doesn't work. Thank you for the opportunity, Blue Health, and thank you, participants. Happy New Year, everybody. So I'm sure we'll. Thank you.
All right. Happy New Year to you too.